Good morning, everybody, and welcome to our Palliative Care Friday Chalk Talk. And today we've got Lindsay Miller, and she's going to be talking to us about palliative ionotropes, specifically Millrinone. And so I'll hand it off to you, Lindsay.
All right, thank you very much. Hi, friends. At the request of the St. Luke's team, we're going to talk about Inotropes today, specifically Millrinone, only because that's really the most popular one that we use here at St. Luke's. There are others that are popular elsewhere, but we tend to prefer this one. So we'll keep things simple. So this is something you guys are probably all familiar with. This is sort of the cascade for how to manage heart failure at whatever stage that it's in. Two things that I wanted to point out here. Rose and I work as part of the advanced heart failure team. And so what does that mean? The advanced care measures come in right here at stage D. That's what we're talking about today. So that's where kind of these measures that we're talking about come in. You will also notice the recommendation that palliative care and hospice are in stage D. I don't recommend that either. I think there's utility for us long before that, stage C or even sooner. And thankfully, we have buy-in, if you will, from our heart failure team that they find value in us getting involved sooner. So generally, Rose and I are getting involved more in these stage C kind of cases. And then we get to know them a little bit better before they actually progress to stage D, and the conversations are a lot tougher. So advanced heart failure options, what are those? Technically, advanced heart failure, as you saw in the last slide, is considered American Heart Association stage D, which means that people who have this stage have symptoms at rest. When we talk about advanced heart failure options, these are some of the things that are involved in that. Some of them are invasive, some of them are less invasive. They're all considered advanced heart failure options. So we have our open heart surgeries, which include things like bypasses and valve replacements, transplants, the LVADs. We have percutaneous options, which are your valves and your stenting. We have temporary strategies, your ECMOs, your percutaneous or your non-durable VADs and balloon pumps. These are things that are going to kind of tether you to the ICU. And you've got your Inotropes. And those are what we're going to talk about today. So Inotropes are drugs that affect the contractility of the heart. There's positive and there's negative Inotropes. Positive will increase the heart's contractility and negative will decrease them. And they each have their role in different types of heart failure and what, depending on what's going on. They are indicated in conditions where there's low cardiac output. Things like cardiogenic shock following an MI, acute decompensated heart failure, or low output states like after cardiac surgery. The idea is that it prevents the cascade that comes from inadequate output, causing hypoperfusion, causing hypoxia, causing a switch to anaerobic metabolism, lactic acid formation, leading ultimately to multi-organ failure and death. So the idea is that, as you all know, we've all seen this formula before, cardiac output is heart rate times stroke volume. It's really pretty simple. If you want to improve the output, you have to improve one of those two things. So your Inotropes will improve the cardiac output, generally by affecting both of them in a little bit. Mostly the stroke volume, but sometimes heart rate is affected as well. And just a little reminder to everybody, one of my favorite things from school, Stirling's Law, all these fun things that we have to remember. The concept that stroke volume can only increase to a certain level before the cardiac muscle fibers become overstretched and the cardiac output will actually drop. So that's just in there as a reminder that, we can't just continually turn up these drips and go up and up and up and up and up as people have more need. A lot of the times these patients have had so many meds thrown at them by the time that they are on the stage of IV Inotropes that the concept of we can't do anything more for you has already been said at some point, prior, yet we still have another trick up our sleeve, we still have a higher dose, a trial or something. Somebody's got an idea that might help. And so this concept of Stirling's Law is really hard for them to understand because up until this point, there's always been something more we can do. And if I'm tolerating this medication at this dose, why can't we turn it up a little bit more? But it's the whole idea that we could actually cause you to do worse. And in some cases, when patients are coming in and they're hospitalized and they're decompensated, we actually do see that, and Rose could attest to that too, that we see patients who aren't tolerating a higher dose, and then we have to have these conversations about turning it down because it's actually helping them more at a lower dosage. So this is where it gets kind of tricky. I'll try to keep it kind of simple but detailed enough. That's hard to do. There's different types of inotropes. So your catecholamines, your PDE3 inhibitors, and your cardiac glycosides are kind of in that same group. That's your digoxin. But to kind of take them categorically, most catecholamines have a short half-life. It's about 2 minutes or so. And steady state concentrations in the blood are reached within about 10 minutes. So usually they're given by continuous infusion. They bind to the, if you can see my mouse here, the beta adrenergic receptors, and it starts the cascade, or it affects the cascade rather, that leads to the production of cyclic AMP, which activates ultimately the calcium channel and increases intracellular calcium, which then makes for a stronger contraction. So if you're still following me there, that's what the catecholamines do. The PDE3, the phosphodiesterase 3 inhibitors, affect it a little bit differently, but ultimately it's kind of the same end goal. PDE3 is an enzyme that's found in cardiac and smooth muscle cells. And this drug, the idea is that it inhibits the PDE3 and increases intracellular calcium by which ultimately causes vasodilation and increased myocardial contractility, excuse me. So this comes in right here. It inhibits this, which ultimately breaks down, in a normal cascade, it breaks down the cyclic AMP right here. So inhibition of this does increase the amounts of cyclic AMP that are floating around, if you will. Which is where we think the arrhythmogenic properties of inotropes actually come from, specifically Millrinone, because that's what falls under this PDE3 category. So inhibition of the PDE3 leads to more cyclic AMP. These drugs can be vasodilators, so we have to be careful with them because oftentimes people have blood pressure issues in addition to their heart issues. So I will say Millrinone, at least by us, is the most commonly used PDE3. It has a relatively long half-life in the grand scheme of things, which means it's about a 2-hour half-life. But it can accumulate in patients with renal failure. So we have to be careful because there, again, we can get these arrhythmogenic properties. I put digoxin in here because one of the sources that I added kind of included it just as something to mention. It acts on the sodium-potassium pump, and it increases intracellular sodium, which increases calcium through the sodium-calcium exchanger pump. So a different mechanism of action, and generally not discussed in the same light of inotropes, but I just thought it was something worth bringing up. Most calcitropes, most inotropes that affect the calcium pump will increase the contractility at the expense of cellular ATP, which ultimately increases the oxygen demand from the patient. So we have to keep that in mind as well. So people have often asked, what is my Millrinone talk? And it basically comes down to 3 points. It's palliative, it's arrhythmogenic, and it has a high mortality. Those are the 3 points that I try to hit when I'm talking to patients about Millrinone. It's really important to note that Millrinone does not make the heart muscle any stronger. It makes it work harder to produce the same effect, the same output as a healthy heart would. So it doesn't actually make the heart muscle stronger, which is something that a lot of patients think that it does. I'm on this drug to make my heart stronger. That is not the case. You're on this drug to make your heart give a little extra, just to make your output match that of a normal person or slightly more normal person. It is a palliative strategy when it's used in the long term. So what I mean by that is patients that are generally seeing Rose and I, they're coming in, they may be already on it, they may be starting it, but the intent is that they're going to go home on it. And this is going to be something that they're on indefinitely. Most people are not put on Millrinone in the hospital and then weaned from it. That is something that some of the cardiologists do. And sometimes it's possible if you're on Millrinone for the first time, your first hospitalization, that you've really gotten to a level where you need Millrinone. Sometimes you can wean from it, but my experience has been, and maybe Rose has something to say about this, that generally if you're at that stage where you're needing Millrinone for your first time and you are able to wean off of it, it means we know what's coming down the road. It means that you're walking that timeline towards needing Millrinone more long-term, and that's something to evaluate whether that's something you want or not.
I would agree with that, Lindsay. I think a lot of times Millrinone, dobutamine, those you're going to see a lot in the ICU, and the goal is to wean off, but oftentimes that's not feasible. Or, I think we always attempt to wean because one of the things that is a big deal about this, which you all probably know, is that it's an IV drug. So it's not like we're sending you home on pills. So if there are issues with the feasibility of someone being able to deal with an IV medication, we're going to try our darndest to wean off of it. But yeah, so I mean, the goal is to wean, but it's oftentimes not feasible.
We have patients that we're following right now whose notes say all over, do not start this person on Millrinone when they come into the hospital, because they don't have the resources to continue it at home. And, all our efforts to get them the resources, they just don't have what they need in the home to make it work and make it work well. They'll be here in the hospital more if we try to send them home on it. And so they've been on it before, and quite frankly, they've been lucky to get off of it prior to discharge. But we know if we put them back on it, we're likely not going to be able to wean back off of it. So that first bullet point, that it's a palliative strategy. This drug does not help prolong life. That's not what it's intended to do. It's helped to improve quality of life. And in fact, it might even shorten it. Some studies have shown that patients who are on it in the long term, again, these patients who are going home on this IV pump, may actually live less long because it can precipitate those arrhythmias. So that brings up another point of conversation, which brings us to number 2 here. A lot of patients who are talking about these meds have already had enough cardiac issues that many of them already have ICDs. Something to talk about, because at a certain point we expect arrhythmias on this. And if your heart is always giving 100%, we'll get to this a little bit more on the next slide, but if your heart is giving 100%, 100%, 100%, we're asking it to give more, give more, give more. When it does have that arrhythmia, it's more likely to be the fatal arrhythmia. And the question becomes, do you want those ICD shocks at the end of life? That's a really tough conversation to have, because a lot of these patients have really learned to trust their ICD. They've had it for years, and for some of them, it's kicked in and it's helped them in the past, and they're alive today to speak about it because of that. So different folks have different goals. We've had people who do go home on Millrinone and do keep their ICD active, but something to talk about.
Hey, Lindsay, Steve had a question about the horse whipping analogy, which I think is always a good one to tell patients.
You know what, Steve? You introduced my next slide. Thank you.
Oh, nice job.
This is an analogy that I use with probably way too many of my patients, but it really illustrates what Millrinone is. There are some docs I've heard explain Millrinone being like rocket fuel, and I like that analogy, but this one I think works better. So in a horse race, you line up your horses, you get them mad at you, you can get them to run, right? You can get a horse to run. But if you, let's see if you guys can hear this. Oh, it's not gonna work. Never mind. I don't need that anyway. If you put a jockey on that horse, you give the jockey a whip, it's going to run a little bit faster yet. It is really going to give its all. The reason that I think that this analogy works really well is because it also helps illustrate the other side of that. Yes, we're trying to get your heart to work harder, but what happens at the end of this? Even a horse that has a jockey and a whip is going to wear out at some point. And when it does, it's going to need to rest. It's always giving its all. It's going above and beyond. And that, I think, really illustrates kind of the arrhythmogenic properties and where this could be going in the future. And actually a lot of patients have thanked me for this analogy because it really helps to illustrate it. So did I miss anything on that, Rose?
I don't think so. I mean, we oftentimes say that crop, that's the Millrinone, you know,
Yep.
that's the thing that's making it work harder.
Mm-hmm. So that is my Millrinone talk. We'll open the floor for questions if you guys have any.
One thing I would say about the arrhythmia situation, there are definitely patients, if we know that they have a known arrhythmia, we're not going to go with Millrinone.
Oh, good point. Yes.
You know, those Ionotropes then are not even going to be offered.
Yeah.
The other thing that oftentimes we get in a funny situation about is if a patient doesn't have an ICD. If a patient doesn't have an ICD and they are going to go on a palliative Inotrope, there are many cardiologists who will say, then this person needs to be DNR, because otherwise we may be precipitating, you know, something we can't get them out of. I've definitely had those discussions with some cardiologists, and it's an interesting one. I understand their point. You know, do you want to, like, this person will ultimately die if they go into an arrhythmia because they'd have nothing to pull them out of it. So therefore, they feel strongly that the person should be do not resuscitate at that point.
Mm-hmm. On the flip side of that, Rose or Lindsay, do they recommend inserting an ICD if they're recommending Inotropes?
Usually the patients don't meet the requirements at that point because to get an ICD implanted, you need to have a greater than 1 year prognosis, generally speaking. So often, no, we're talking life vest, if anything, or just frank discussion about what this all means in terms of the bigger picture.
Thanks.
Do you ever encounter a patient then who says, well, then give me an ICD who wants one then, so that they don't have the likelihood of having a arrhythmia, a lethal arrhythmia?
Usually my conversations with them are, we're at a stage where no option that we have is totally without risk. And this is the inherent risk of this medication. We expect it to help you more than hurt you, but you do need to know what you're signing on to. You know, the reality is patients in this stage of disease, they have a high risk of sudden cardiac death at any point. To be honest, this doesn't help matters, of course, but if they're absolutely unwilling to accept the fact that Millrinone may come with a higher risk of arrhythmia, I think we need to have a more honest conversation about where they're at in their disease process too.
Steve brought up a good point in regards to the challenges with Millrinone and any IV inotrope. If you are discharging, you will not be accepted in a SNF.
Yes.
That is just not going to happen. They are usually concerned about cost, although it's actually not that expensive. But I think they're also kind of afraid of the management. So people who go home with an inotrope, go home. There aren't other care options. I think, Lindsay, you want to talk a little bit about hospice and inotropes?
So when patients go home with inotropes, it's logistically speaking, they usually follow up with home care or home palliative care, at least initially. They have a nurse coming out about once a day, once every 2 days, depending on the rate of their Millrinone, to change over their bag. And over time, patients are learning how to mix it themselves and things like that. So those are just logistics that you guys need to know about going home with IV medicine. Hospices, sometimes it can be tricky. Rose and I have found that we tend to prefer certain hospices over others in certain situations just because of their willingness to work with Millrinone. Again, some patients have been on this for a while and they've really learned to trust it. It helps give them quality of life. And again, we're not talking running marathons and climbing mountains. We're talking like you can get to the bathroom without shortness of breath, you know? And so that's a really important part of their quality of life. And if they're going to go home under hospice, some of them do wish to continue it. And so sometimes we are having conversations about how long do you wish to continue this? Is this an indefinite thing? Is this something we can wean from? Is this something, you know, those kinds of things. But Is there a certain particular point about hospice, Rose, that you were getting at?
But it can be tricky. My recommendation would be ask a lot of questions. And sometimes what will happen in our situation is, you know, the patient will go home with hospice, their primary will manage all of their hospice needs, but the advanced heart failure clinic will take ownership of that Millrinone if there are needs as far as titration or anything like that, because not everybody's comfortable with it. And I guess in regards to Zilber, again, I think it's case by case. We did have a patient whose plan was to actually go to Zilber and be there. He wanted to stay on Millrinone till his birthday, which was like 2 months away. We were able to facilitate that. He actually passed away on the Millrinone, I think, before that.
Before that, yeah.
And so I just really recommend trying to work with people, you know, and because sometimes I think people are just afraid and they don't know much about the med. So if you can, you know, do that. Oh, good. And Dr. Battle Miller says, advocates able to accept stable Millrinone infusions. That's great.
Oh, wonderful.
Because it really, you know, people feel better very quickly. You will know if this is going to be something that they're reacting to. They have more energy. They have more, you know, less symptoms. And you'll know pretty quickly if this is something that's going to help them.
Other questions about the topic? No. I see we went past time. I'm sorry, guys.
Great information.
Guys.
Thanks so much, Lindsay.
Thanks for joining us.